small topics in stomach from Sabistan and Variant. You must know those topics. The first topic is this: the boy is a small baby presenting to the hospital. It's a clinical topic. Small baby is presenting to the hospital. By 4th week, the mother is lifting the baby to hospital. And what is the clinical picture the mother is telling? Let me discuss. This is a pakka clinical topic you'll get in AIIMS and other institute exams also. Please don't forget. Congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. I'm going to discuss now. So mother presents the baby with a clinical feature of non-bilious vomiting. Please remember, it is a non-bilious vomiting. Mother brings the baby with a non-bilious vomiting. Baby is having non-bilious vomiting, and the mother is noting after consuming milk, the baby is developing a mass in the right hypochondrial region. Hypochondrial region, the baby is developing a mass, and the baby after consuming the milk having a non-bilious vomiting. So this is exactly seen by around the 4th week of a firstborn male baby. Firstborn male baby usually gets this disease. So now let us discuss about this. Like this, the mother brings the baby with a non-bilious vomiting, and on time of vomiting, the mother is noting the baby is getting a lump in the epigastric and right hypochondrium. It is presenting at 4th week, and it is common in firstborn male baby. Now the questions. Discussion of this. So congenital hypertrophic pyloric stenosis. What actually happens in this case is, in this, due to some unknown etiology, the circular muscle of pylorus gets hypertrophied. Circular muscle of pylorus gets hypertrophied and thickened. So what happens? As soon as the baby is consuming milk, on examination, the following findings can be noted. Inspection must be done when the baby is consuming milk. While consuming milk, we should inspect. While baby is feeding, at the time of feeding, you should inspect. Then only we can note what finding. What finding we can see. The baby is continuously drinking milk from the mother. At that time, you examine the baby's abdomen, you can see the VGP. VGP is noted at the time of consuming milk. Palpation. You must palpate only during non-feeding time. If you palpate during feeding time, you cannot palpate the mass. In a non-feeding time, if you go and see, there is a mass of the circular muscle hypertrophy palpable. So circular muscle hypertrophy is palpable. So where is it seen? Where is the circular muscle hypertrophy mass seen? Actually, it is seen towards right hypochondrium more commonly, because the pylorus is more lying in the right hypochondrium. So it is a right hypochondrial mass. It is usually seen in the right hypochondrium on palpation. So this question came in NEET 2018. So inspection is done during feeding time. Palpation is done during non-feeding time. This is a direct line from median law. On inspection, you will see VGP. On palpation, you see a right hypochondrial mass. And don't forget, it is seen in firstborn male babies. Firstborn male babies will get this commonly. So when a baby like this comes to your hospital with a GOO, gastric outlet obstruction, she will have the classical features of hyponatremic, hypokalemic, hypochloremic, metabolic alkalosis is present in these babies. On presentation, the baby will come to you with an electrolyte imbalance. Sodium, potassium, chloride, everything is gone because of continuous vomiting. Since the obstruction is at the pylorus level, there will be no bile vomiting. It is only a non-bilious vomiting. Please don't forget this point. Don't forget this point. So now coming to the next important issue in this is investigation of choice to diagnose. Investigation of choice to diagnose is ultrasound abdomen. Ultrasound abdomen will show you the following clinical features. The pylorus will be thickened. The pylorus wall will be thickened for 4 millimeters. Please remember, the pylorus wall is thickened for 4 millimeter thickness and lengthened for how many millimeters? 16 millimeter length. So on ultrasound, what are the findings mean? The pylorus wall is 4 mm thickness. Pylorus wall is 4 mm thickness present, and length is 16 mm length is present. This is a direct question from AIIMS, and there will be nothing in the stomach. Stomach will be empty. Stomach will not contain food. It will be empty. Stomach will be empty. So empty stomach, 4 mm thickened pylorus, 16 mm lengthened pylorus. Please don't forget this point. So this is the investigation of choice. Olden days, they used to do barium meal. The barium meal will show you string sign here because of thickness here. The pylorus is very much thickened here. We will see a thin contrast going like this. So you will see a string sign. String sign will be seen near the pylorus in a barium meal. So olden days investigation, nobody does that now. So nowadays we are doing directly only ultrasound. How is the baby? Baby is good or malnourished? How is baby? It's a malnourished baby or a healthy baby? Interesting point is the baby is healthy. That is, they are not malnourished. They are healthy babies. How? Because of vomiting. Why they are not getting weak? The reason is the baby will vomit, but after vomiting, the pyloric mass suddenly disappears, and in that gap, the baby drinks more and more milk. It is not a constant phenomenon. Congenital hypertrophic pyloric stenosis causing non-bilious vomiting is not a constant phenomenon. It is intermittent phenomenon. So the baby will be healthy. This is one interesting point. And another interesting point from Sabistan is, if clinical examination shows mass present with the typical findings, what I have told you, typical GOO findings with the mass, no need of ultrasound, directly you can operate. This is a line from Sabistan. Directly you can operate, no need of ultrasound also, if there is all clinical findings seen. So when there is no mass palpable only, Sabistan advises to do ultrasound. When you are palpating, no mass is seen, at that time they are advising ultrasound. And in fact, Sabistan says you can directly operate if you have typical clinical findings. So the surgery is very simple, Ramstad's pyloromyotomy. So Ramstad's pyloromyotomy, what is done in Ramstad's pyloromyotomy? Can you tell me? So in Ramstad's pyloromyotomy, we just cut open the circular muscle. This is the circular muscle. No, we cut open the circular muscle. Like this, we cut open the circular muscle up to mucosa and submucosa. We don't open the mucosa. We just cut open the muscles alone. The tight contracted muscle is made open. That's all. It is made open. That's enough. So the GOO gets relieved. So it can be done by laparoscopy or open method. If the procedure is successful, we can start oral for the baby in 6 hours. If surgery is done successfully, you have not opened the mucosa, start oral in 6 hours. But accidentally, while you are operating, you open the mucosa. What will you do? PJ Chandiya question. Mucosa opened accidentally. We have to keep the baby nil oral for 24 to 48 hours. Nil per oral should be kept with a Riles tube aspiration done. But what I will do, if the mucosa is opened, I will not repair everything. I will only repair mucosa with a 3-0 Vicryl. Repair mucosa alone with a 3-0 Vicryl and keep the baby nil oral for 24 to 48 hours. A small mistake what we are doing will make the baby nil oral for so many days. So please remember, this point is very important for your exams. Okay, this point I want you to remember. Ramstad's pyloromyotomy. If successful, start oral in 6 hours. If not successful and if I open the mucosa, we have to keep the baby nil oral for 24 to 48 hours. Please remember this point about congenital hypertrophic pyloric stenosis in babies. Topic 2. I'm just discussing some miscellaneous topics. Topic 2. So in topic 2, what I'm going to discuss is, please remember, the same 4 weeks the baby is brought by the mother, but this time the baby is having not non-bilious vomiting, baby is having a bilious vomiting. What are the causes? bilious vomiting in a newborn baby, you must think of the following causes. What are the causes means? You should think of the following causes. The first important and the most common cause is this. What is it? That is a atresia of the duodenum. Atresia is usually seen distal to the ampulla. Distal to the ampulla. Atresia is usually seen distal to the ampulla. Therefore, the babies will have bilious vomiting in 80% of the cases. 80% will have bile vomiting. So in remaining 20%, atresia is more proximal and they may also come to you with a non-bilious vomiting. Okay, 80% of them, the atresia is distal to the ampulla, so they get bilious vomiting. It doesn't mean they should only get bilious vomiting. 20% will have non-bilious vomiting also. If the atresia is more proximal, they will get non-bilious vomiting also. Please don't forget this point. I want you to remember this point, very important for exams. Very important for exams, please don't forget this. And this patients, when you take X-ray abdomen erect, what finding is seen in these patients with duodenal atresia? So this is one commonest cause of duodenal atresia, is one commonest cause of bilious vomiting. There are many other causes are there. X-ray abdomen will show you double bubble appearance. I will show you the image. X-ray abdomen erect will show you double bubble appearance. Congenital hypertrophic pyloric stenosis will show you single bubble appearance. CHPS will show you single bubble appearance. Duodenal atresia will show you double bubble appearance. And there is one more rare condition, jejunal atresia. Will show you how many bubbles? Will show you triple bubble appearance. There will be 1, 2, 3 bubble appearance. So the first bubble is gastric bubble and second bubble is duodenal first part bubble. So in the duodenal atresia, the first bubble is stomach is distended with gas. Second bubble is duodenal first part is distended with gas. Usually they vomit and you will never get a distension. Most of the time they will vomit bile vomiting and distension is very rarely seen. So they will have typical epigastric fullness because of this thing. And duodenal atresia, treatment is what? So this question is very classical question. The treatment of choice for duodenal atresia is duodenostomy. We have to make a diamond-shaped incision and we have to make anastomosis between the duodenum, which is more proximal and more distal. This is a thing. So please remember, we have to make a diamond-shaped incision like this and make anastomosis between this bubble and this bubble. Duodeno. After making the incision, you can fold it like this. It becomes duodenal anastomosis. So this is the treatment of choice for duodenal atresia. Please follow this. This is the treatment of choice for duodenal atresia. Please don't forget. So then comes the topic 3. I want to discuss the topic 3. The topic 3 is going to discuss about disorders. So psychiatric patients, they continuously pluck their hair and eat the hair. So what happens? As they pluck and eat the hair will go and get obstructed in the entire stomach like this. And this forms a disorder looking like the same shape of your stomach. This is known as trichob. If this hair extends into the duodenum, jejunum and ileum like this, what is the syndrome known as? It is known as Rapunzel syndrome. You have remembered this character? She is a cartoon character of the movie Tangle. So Rapunzel syndrome she is a cartoon character of the movie Tangle. She will have long hair extending to jejunum and ileum. So that is Rapunzel syndrome. So long hair into the small bubble. It's known as Rapunzel syndrome. So trichob is presence of hair in the stomach. Similarly, we can also get phytobazar. Phytobazar means presence of vegetable particles. It is also seen in psychiatric patients and diabetic patients also. In diabetic patients after eating vegetables, they get the vegetables lodged in the stomach. That is known as phytobazar. So diabetic patients also will get phytobazar and psychiatric patients also will get phytobazar. That is due to gastroparesis. In diabetic patient happens because of gastroparesis or incomplete digestion that will be lodging there. Similarly, we can also get iron particles. I will show you one video of iron particle bazar. So all these are various bazars. Bazars will need surgery if it is causing GOO. Many times we have to open the stomach and remove the bazar particles. Okay. So then comes the topic 4. So topic 4 is a very rare case, gastric volvulus. Gastric volvulus is a very rare small topic. So gastric volvulus. What is gastric volvulus? Please remember, volvulus of stomach can happen in 2 directions. This is longitudinal direction. This is mesenteric axis. This is mesenteric direction. So this longitudinal direction is known as organoaxial volvulus. This is more common. Organoaxial volvulus is 80% of the patients will develop organoaxial volvulus. 20% of the patients will develop mesentericoaxial volvulus. Mesentericoaxial. So organoaxial means if you see this is the stomach. If this is the stomach, organoaxial means it will turn up like this. It will turn up like this. Like this it will turn up. Organoaxial. Mesentericoaxial means if this is stomach, it will turn up like this. Mesentericoaxial it will turn up like this. Organoaxial it will turn up like this. So please remember there are 2 volvulus. Organoaxial is most common 80%. Mesentericoaxial is 20%. Organoaxial volvulus is usually associated with, this question is asked in exam, is associated with diaphragmatic hernias. So associated organoaxial volvulus is associated with diaphragmatic hernias. So both these volvulus will need immediate surgery, otherwise the stomach will go for gangrene. And especially organoaxial, we have to immediately treat them. And it has a triad known as organoaxial volvulus has a triad known as Burchard's triad. What is Burchard's triad? So the stomach is like this now. The stomach has become like this now, and this area is twisted. This area is twisted. So you are trying to pass a Rayleigh tube. Will it go inside? It will not go. It will come out. So the Rayleigh tube is inability to pass. The first point in Burchard's triad is inability to pass Rayleigh tube. Inability to pass Rayleigh tube. First point. Second point, the patient, because of severe torsion of the stomach or volvulus of the stomach, the patient will have retching pain. Patient will have retching pain in the epigastric region. Retching pain will be present. Inability to pass Rayleigh tube. Patient having retching pain, and whatever there in the stomach, he will try to vomit, but vomiting will not come. Inability to vomit. So this is the Ames question. Please don't forget what is Burchard's triad. Burchard's triad is a triad seen in gastric volvulus, organoaxial type in which inability to pass Rayleigh tube, retching pain, inability to vomit. Please don't forget. So in this, usually the following are the features of Burchard's triad. The examiners will keep the patient has copious vomiting or severe vomiting or bilious vomiting. Something they will keep. No vomiting is possible for them. That is answer. Inability to vomit. So Burchard's triad, inability to vomit. Please don't forget this point. Okay. Please don't forget this topic 4. Topic 4 very important for your exam. So coming to topic 5, I want to tell you that topic 5. Topic 5 is going to discuss about 2 rare diseases. Very interesting diseases. So this is topic 5. Disease number 1 is the patient has on endoscopy an appearance looking like a watermelon. That is looking like a watermelon appearance on endoscopy, known as watermelon stomach. So watermelon stomach is nothing but gastric antral vascular ectasia. This is otherwise known as watermelon stomach. So gastric antral. So please remember, the antrum has vascular ectasia. It is common in old females. These cases present with the clinical feature of melena and iron deficiency anemia. These cases present with melena and anemia. So treatment of them is very simple. We can treat them easily by passing coagulation, APC, on this abnormally dilated vessels. APC, argon plasma, coagulation is enough. So the watermelon stomach or gastric antral vascular ectasia is common in old females. They have melena and anemia. The treatment is very easy. APC, organ plasma laser coagulation is enough. So one more condition in which there is an abnormal dilated vessel on the lesser curvature over here. See the note the point on the lesser curvature 6 centimeter below OG junction. 6 centimeter below OG junction on the lesser curvature there is an abnormal dilated artery which is actually a branch directly from the left gastric artery which is spurting out blood. It is spurting out blood. Blood is pouring everywhere. Blood is pouring everywhere. Patient presents to you with a hematemesis. What is this case? So two cases of bleeding inside stomach I am discussing. The first one is melena and anemia, only mild bleeding, but this case having massive bleeding, hematemesis. So what is this case? This is Dielophy's disease. So Dielophy's disease, where is the lesion seen? On the lesser curvature side, 6 centimeter below OG junction. On the lesser curvature side, 6 centimeter below OG junction, there is a submucosal artery which is bleeding. Immediately you must treat by endoscopy clipping. Endoscopy clipping or coagulation should be done immediately. If this fails, you call the radiologist to do left gastric artery embolization will be done. That is also failed. We have to go for a surgery. So please don't forget these two topics. So GAVE, gastric antral vascular ectasia, is otherwise known as watermelon stomach. Dielophy's lesion presents with severe hematemesis. Please don't forget these 2 points. Okay, you should not forget this topic number 5, GAVE and Dielophy's lesion. So now coming to topic number 6. So topic number 6 is one which I discussed already, Meniere's disease. Meniere's disease, it's a hypertrophy of gastric mucosa. Hypertrophy of gastric mucosa. How does it look? When you see the gastric mucosa on endoscopy, it has multiple mucosal folds like this. It looks like a brain. It is known as cerebriform pattern of mucosa. Cerebriform pattern of mucosa is seen. Hypertrophied gastric mucosa looks like cerebriform pattern of gastric mucosa. It is due to the parietal cells. The parietal cells are replaced by mucus secreting cells. The reason for this disease is the parietal cells are replaced by mucus secreting cells and these babies lose protein. There is a protein losing gastropathy. It is a protein losing gastropathy. When you see the babies, they will be hypoproteinemic with full of edema all the body. So Meniere's disease is a protein losing gastropathy due to hypertrophied gastric mucosa. The parietal cells are replaced with mucus secreting cells. Etiology, they have found it is usually due to cytomegalovirus in children. Not confirmed, but it is all some fact, some disease associated, and they are associated with H. pylori in adults. So etiologically, they have found the cytomegalovirus is more associated in children and H. pylori in adults. And here comes the main question: what growth factor is elevated? TGF alpha is elevated in Meniere's disease. Please don't forget this point. 100 times asked MCQ. So in Meniere's disease, what is the factor elevated means? TGF alpha is elevated. And I already told you it is pre-malignant condition, and we may be forced to do gastrectomy if it is not getting cured. We may even do gastrectomy if there is continuous protein loss. Okay, initially we give protein supplement, and if it is keep on having protein losing gastropathy, we have to do gastrectomy because it has a risk of pre-malignancy in future. Coming to topic number 7. So topic number 7 is a disease known as Wilkie's disease. Wilkie's disease, also known as what? Superior mesenteric artery syndrome. Superior mesenteric artery syndrome, also known as Wilkie's disease. What is done? What is actually happening in this? So please understand the picture I'm drawing. It's a very classical case, very classical picture I'm going to draw now. So please understand. Now what happens? So this is aorta. From aorta, superior mesenteric artery is arising and crossing the third part of duodenum. You can see it is crossing the third part of duodenum over here. So now what happens? In young, tall, thin females, these girls will go for dieting. They will reduce the food intake and they go for dieting. And suddenly what happens as they go for dieting and reduce the weight, the paraduodenal fat present here will be lost. As the paraduodenal fat is lost, the superior mesenteric artery compresses the third part of duodenum and results in a syndrome known as Wilkie's disease or superior mesenteric artery syndrome. It is also known as cast syndrome because it is also seen in some people who wear body cast. Some people also will get this. So it is also known as cast syndrome. Wilkie's disease, SMA syndrome, cast syndrome. Who gets this commonly means usually young, tall, thin females. Young, tall, thin females get this disease commonly. Please don't forget this point. It is also seen in chronic immobilization. Chronic immobilization is another cause. Application of body cast is another cause. Wearing tight dresses is another cause. Tight dress. Some people used to wear tight dress to make them slim. So tight dress is also another cause. All this thing will cause this superior mesenteric artery syndrome, and the compression is at third part of duodenum. It is at the third part of duodenum. Okay, so this angle between aorta and the superior mesenteric artery is known as, what angle is it? It is known as aortomesenteric angle. This is taken from Shackelford, but asked in James. Aortomesenteric angle is normally 35 to 65 degrees. The normal angle should be 35 to 65 degrees. If the angle becomes less than 22 degrees, it is known as Wilkie's disease. So the angle from 35 to 65 becomes less than 22 degrees. It compresses the duodenum and causes the syndrome Wilkie's disease. What substance says? Initially we manage them conservatively. Initially conservative management. We increase their nutrition support. High protein diet is given. Slowly increase their weight. So by managing with the diet and postural adjustment, after eating they will be lying one side laterally. So postural therapy and conservative diet can cure this disease in 80 to 90% of the time. If it is not getting cured with this, we will do duodenojejunectomy operation according to substance. Duodenojejunectomy operation. So duodenojejunectomy, see now in this picture, this will be anastomosed like this, so that the food particles now will go through this way like this. So this is a duodenojejunectomy operation. This is what Sadiston recommends. But Shackelford says one procedure known as strong procedure. So please remember this question has come in Ames last year. Strong procedure. What is strong procedure? There is no anastomosis in this procedure, and this is the best procedure. What is strong procedure? Very simple. This is DJ flexure with the ligament of Treats, and this is aorta, and this is SMA. What I will do now is I will cut this ligament of Treats and mobilize the duodenum from inside and bring it outside like this. Now you see, I have brought the duodenum which is going inside this aortomesenteric angle. I have let it out. I have brought it out. So this procedure is strong procedure. Removing ligament of Treats. Removal of ligament of Treats and straightening the duodenum. So this is a simple procedure because we are not doing any anastomosis. So the concept is we have to bring the compressive segment out. We have brought it out, and this procedure, strong procedure, is expected MCQ from Shackleford for PGME exams also, already asked in exams. Okay, let me show you the images now from this topic. So this is a topic 1. You can see the baby is having a VGP. Inspection is usually done during feeding times. Palpation is done during non-feeding times. See, this baby is having a Riles tube with a non-bilious vomiting. So this is Ramstad's spirometry. You should note very carefully. We are not opening the mucosa. If mucosa is not open, we can start oral diet in 6 hours. So this is double bubble appearance duodenal atresia. This is triple bubble appearance jejunal atresia. Both of them will have bilious vomiting. So this is topic 3, trichobazar. You can see such an enormous amount of hair in the stomach. And this syndrome is what I told you, Rapunzel syndrome. And for those guys who are not knowing who is Rapunzel, this is Rapunzel. This is taken from the movie Tangled. From the movie Tangled, she is a heroine of the movie Tangled. You can see this girl is having such a long hair. She'll be having a long hair. And she is Rapunzel syndrome. Okay, that is Rapunzel syndrome. And you can see one of our patients had iron bazaar, full of iron particles. You can see we are removing all the iron. She had around 6 kg of iron in the stomach alone. See, we are removing the iron particles one by one. We are removing the iron particles one by one. So keychain, nails, multiple iron nails, chains, everything was there. Around 3 kg, 6 kg of iron particles are removed. That's the Riles tube. And you can see all the iron particles. We are continuously removing all the iron particles, and finally we waited. It was 6 kg. And this is the gastric volvulus. You can see the stomach is upside down. Upside down. This is organoaxial volvulus. This is organoaxial volvulus. This is mesenterico-axial volvulus. Mesenterico-axial is very rare, less than 20%. Organoaxial is common. Don't forget, both shots there will not have vomiting. So topic 5, you can see this is a picture showing you that watermelon-like appearance gave, and the treatment is this. You use organ plasma laser coagulation. And this is a dilophoid lesion. I am putting an endoscopy and seeing by a J manual there is a lesion here. So you can see this is a lesion. Endoscopy clipping being done. This is dilophoid. So dilophoid is seen 6 cm below OD junction. So this is many tears. This is TGF alpha elevated. The gastric mucosa looks like a brain. TGF alpha elevated. And this is Wilkie's disease. You can see the duodenum being compressed here, over here, and the angle should be less than 22 degrees. Iotomesenteric angle less than 22 degrees is SMA syndrome. Normal angle is 35 to 65 degrees. Please don't forget, this picture shows you the strong procedure. You have cut the ligament of Treats and brought it out. So this is strong procedure. Nowadays, nobody does duodenojejunectomy or gastrojejunectomy. People do only strong procedure. So on a endoscopy, you are seeing a wide hiatus hernia with an ulcer. What is this ulcer? It's a old image-based question. Already discussed in the first topic. This is Cameroon ulcer. Hiatus hernia showing you Cameroon ulcer. Please don't forget, on a J manual with a hiatus hernia, you are seeing an ulcer, Cameroon ulcer. So this is a bariatric surgery. Rule limb is done, and behind the rule limb there is a herniation. What is this hernia? It is Peterson hernia, some image-based questions. So this is the manual I told you. You will put inside and see up. When you see up, the scope also will be seen. This is a J manual showing you gist. So that's about the miscellaneous topics. All are important topics for your exams. Please memorize them thoroughly. Okay, thank you.